Assalamu alaikum. Good morning, ladies and gentlemen. It's a pleasure to be with you here today, and I'm happy to see a full class compared to our auditorium. But I guess most of our attendees are virtual. Let's assume they are there. So why did I choose to have the nuclear medicine pros and cons? I was speaking to my new colleague who I just came to know from USA, and saying the reason for I chose this topic because I was requested by the organizing committee to choose another topic in addition to my first one, which is fundamentals in nuclear medicine, and I didn't know what am I supposed to talk for the other parallel session. But then I am talking to one of my recently assigned consultants in nuclear medicine who's dual qualified, and she said, before going to a fellowship in nuclear medicine, one of the senior trainers in radiology told me, are you sure you want to go for nuclear medicine? It's a dying specialty. So I said, fine, that's it. My topic will be what are the pros and cons of nuclear medicine, not defending what we are doing, but we are just showing what are the things that we can do and answer questions that no other imaging modality can, or we can improve the imaging of those patients. So the first slide is something that I've used before, the differences between nuclear medicine and radiology. And again, I mentioned we image physiology and biological processes, and the medical imaging, meaning CT and MR, are doing the anatomical images. And having said that, as mentioned before, we do have some anatomical images with the hybrid imaging, and they do have some physiological imaging as well. So what is the importance of examining physiology and function when it comes to nuclear medicine? It allows us in nuclear medicine, and probably I'll show you some of the examples we have a good number of technicians, physicists over here, that you're helping in really answering some questions that only nuclear medicine can do and change the patient management. So we can have the early detection of the biological changes, and I think I've seen, or you've seen with me the slide that I've used before. I'll show it with you again. We do have a renal DMSA, as simple as DMSA scan, which is really very simple, but it can answer questions that sometimes, even with us in CT, or even we have to go with contrast-enhanced CT in order to see the changes where DMSA can show it readily. Ultrasound is no ionizing radiation, but sometimes we can't see the very early changes. The renogram and the simple renogram that we do can differentiate and can really make a big decision when it comes to obstructed versus non-obstructed hydronephrosis. We have 1-year-old child, 2-year-old child who has been operated for pelviureteric junction obstruction, which is a congenital anomaly, one of the commonest in pediatric. And then you go to ultrasound and you see there is dilatation. Should we go again and operate on them, or should we not? By doing the physiological imaging, which is injecting a diuretic, you will have the answer. So you are really doing a lot of answers that other imaging will not be able to do. Gallbladder ejection fraction, sphincter of OD dysfunction. I had a patient I've seen 1 in 10 years in which he presented with a typical presentation of acute cholecystitis. Ultrasound, no gallbladder stones. They said, okay, it's dysfunction of the gallbladder, acalculous cholecystitis. He came to us. We did the gallbladder ejection fraction. It was normal, but there was a delay in the biliary to bowel transit time. This is a rare, but yet it can be diagnosed with nuclear medicine, which is dysfunction of sphincter of OD. With sphincterotomy, doing ERCP, with sphincterotomy, the patient was symptom-free. So he was so happy that he didn't have to have cholecystectomy, and we were so happy that we were able to help him. Again, this is physiology. Or looking at the biliary atresia. Again, we can do ultrasound, but the recent updated guidelines, whether seeing the gallbladder in those newborns or not seeing the gallbladder, again, you cannot exclude biliary atresia. And diagnosing biliary atresia is something huge. It's a major decision because those pediatric age group will go for liver transplant. So it's really answering questions that other imaging modality will be difficult to answer. The thing is, and you've seen this before, I think, the biological changes which is happening or taking place from the initial stage of the cancer until it becomes tumor, it's really not happening overnight. So things will take years and years to develop. And the earlier we can detect, as I've seen this, you've seen this before, the better we can and earlier we can diagnose and then help them in managing those patients. Now this is an example of one of the patients that we have published, and this is a group of patients in which the PET-CT has changed the management. For example, this is an esophageal carcinoma for staging with bone scan. And the bone scan was totally reported as negative. As you can see, there isn't any changes that you can see that we can report as metastasis, whereas the PET image and the fused PET images are showing a very early changes that bone scan and bone scan only could have missed it. So upstaging those patients. Or detecting, whether the biological changes are there as a viable or versus non-viable. This is a major thing when it comes to the patient's family, as well as the treating oncologist. This is another example in which you can see CT is showing that there is a residual disease still remaining, but the FDG is showing there is no viable disease. There is something which is still there, anatomically, yes, but biologically it's not viable, so you don't have to worry about treating it, you just have to follow it up. Or again, another example of physiology versus anatomy. This is a very interesting, this was like last month, case from our department, a 1-year-old child, I guess, or 2-year-old child, with incidental finding of what they looked like, and they were saw in the ultrasound, like a mass in the upper pole of the left kidney. And what we simply did, the simple DMSK. DMSK scan has showed us that, yes, there is an uptake, but this radiotracer uptake is in the normal kidney tissue, is in the normal cortex. And this is not a tumor, because if it has a tumor, it wouldn't show any DMSK uptake. It will be photopenic, meaning that this is a normal variant, or this is just what we call hypertrophy of column of Burton, which is part of the renal tissue itself. It is not a tumor, and it's a big relief for both the physician as well as the pediatrician as well as the family. The other thing is the metal implants or artifacts. This is a patient, this is a real patient who had Whipple's, and Whipple's procedure is a resection of the pancreatic tumor, and they do a lot of resection around this. So they remove the gallbladder, they do a lot of anastomosis, they remove the spleen and kidney. And because of the lots and lots of sutures that you can see, and this is in reality, the contrast CT was stopped. They couldn't continue because it's lots of artifacts. They couldn't, it's useless to do it. Whereas if you look at the PET image, you see that there is a potential abnormality over there, and you see the PET image versus the CT. The metal has no effect on the image quality. Yes, on the fused, you can see it, but again, you will be appreciating the abnormality even with the presence with the metal artifact. This is another example of one of the patients that I've seen with mandibular cancer, bone metastasis, and an implant. And I'm glad I have this picture, because yesterday or day before I was to Qatar, and I knew that they just lost those 2 pigeon towers. Those are pigeon towers. They were demolished or something by the heavy rain, so I'm glad I have it documented with me. Now, the other thing that we know, and I've discussed this before, the emission versus transmission. And because we can it's not that it is the nature of nuclear medicine, it's emission, we can do as many images as we need. We can do the static images, the interior images, the oblique images, the delayed images, and this is something that I have always to repeatedly say to our radiology resident, because we have a joint radiology, we have a radiology program in Oman. We don't have one nuclear, so they do come for rotations in nuclear medicine, and the first day after introducing them to the department and everything, I tell them, remember, you can do as many extra as you want, there is no extra radiation. Because in radiology, we do PA chest, if we want lateral, we have to have a clear indication. In here, we don't. But just be mindful with the time, because otherwise the technicians will hate you if you have lots and lots of extra images to do, but there is no extra added radiation. Precision. Now, this is really the beauty of nuclear medicine, because this is an example of somatostatin receptor detection. There is a a 35 years old female, and this is from our hospital, known to have multiple endocrine neoplasia type 1. She has pituitary adenoma, parathyroid adenoma, and she presented with chronic diarrhea, and CT abdomen was reported as normal. This is the CT abdomen, and there was a pre-pancreatic lymph node, as you can see with the circle, and it was reported as normal. There's fatty hilum, it is 7 millimeters, it's normal. We did the technetium octareo scan. This is our images from our center, and the uptake in the mid-small bowel wasn't normal. There's an abnormality over there. And I myself went back and discussed it with our body imaging radiologist, and I told her, there is abnormality over there. We can see something. It is showing the uptake. The same lymph node that you reported as normal is actually showing somatostatin uptake. This is abnormal. She went back, and I told her, there's the proximal mid-bowel uptake. No, it was reported as, this is a collapsed, non-distended bowel, and this lymph node looks normal. We insisted it's not normal. In the MDT, the patient went for gallium DOTA scan, and actually this wasn't normal. Showed uptake in the mid-small intestine, showed uptake in the this lymph node, and showed uptake also in the pancreas. And the patient went for Whipple. So this wasn't really normal. The other precision that, and this also we have it from our hospital, is the PSMA. Now, you've heard a lot of the PSMA, probably attended some of the lectures of the prostate-specific membranous antigen, which is very specific for prostate cancer. This is an example of how precise it is. Look into the bone scan, and this is the bone scan, and this is the technetium PSMA scan. Patient is known to have widespread bone metastasis. We know that already. So why am I showing this? Is for this lesion. Look into the left clavicle, the medial end, which showed intense uptake by the MDP. Looking at the same site on the PSMA, there's no uptake. Does it make a difference? It doesn't. I mean, he's got a lot of bone mets. But what this indicates is the patient has a history of trauma. He's got a fracture in the medial end of left clavicle. That's why the repairing mechanism, the osteoblastic activity, is so much active. So it is in the bone scan, but it is very specific when it comes to PSMA. There are no metastatic lesion in that bone. There is no uptake. This would have made a lot of changes if this is a monostatic lesion. Of course, in this patient, it won't do anything, but it just teaches us how precise it is when it comes to the imaging the receptors. Radiopharmaceutical safety. I have a background of radiology, and I've seen several, at least mild form of contrast reaction, and we have to deal with them. At least not to the level of intubating the patient, because if they go to that level with angioedema, we have to shift them to the A&E, and we had to do it once in my residency and after residency. But I've never, and for the last 10 years, I've never seen any reaction to the radiopharmaceuticals that we've used, although some of the leaflets might mention there is, or caution to be taken care of, but we never had anything. We can do it, and we are the only imaging that we can do for patients with renal failure. It has no nephrotoxicity. We can do it with liver failure. It has no hepatotoxicity. We do it for a 1-year-old newborn. And again, it doesn't affect, there is no toxicity or organ toxicity known to the radiopharmaceuticals. And this is another image from our southern part, which is Salalah. Now, what are the disadvantages? What are the cons that we can see that might be taken when it comes to nuclear medicine? A long waiting time. This is one of the things that we do have in nuclear medicine, and we have to admit, between the ingestion or inhalation might not be, but injection and ingestion, we have to have the patient waiting for a long time in our department so that they will get scanned, and this is part of the increasing the target to background ratio. That's what we want, unless you're doing a 3-phase, for example, or a dynamic study. So why am I saying this? It will be good to invest in your waiting area. I always wanted to have a fish tank in the waiting area. I never managed. If you are planning a new hospital, have one, or reading, or books, or something that the patients can wait. And we managed finally to have a small play area for the kids to play in. So it's something that you might have to consider, because this is one of the things that patients or families might think, okay, going to radiology, just finishing in 10 or 15 minutes is much faster. Yes, this is something that we have to face. The other thing is the long waiting time between, again, the ingestion, or your reporting. And this is to have to be very careful when you are in a joint radiology nuclear medicine department. You set your KPIs. Fine. When you do your KPIs, you cannot have the same KPIs of report done or procedure done till reporting, because sometimes you can have it done, like for example, post-iodine therapy in 3 days, but you need a delayed image. You do it after 8 days. If we compare that to CT contrast chest, abdomen, pelvis, it will be done within 1 hour. So why the KPIs of nuclear medicine is not doing well? Because they have their own time between the procedure done and the report released. This applies to the urgent, this applies to the routine. So your KPIs has to be arranged in a separate way. If you are a separate department, that's not an issue. Radiation dose. And I'm not the expert and I'm not the qualified person to talk about radiation dose. I think it's a room full of physicists, so they will be talking about radiation dose. But yes, we had radiation doses higher. This one started with thallium, with gallium. We do have some radiation doses higher when it goes to radionuclide therapy. But I think we managed also to have less radiation when it comes to using technetium. And then also we know about the biophysiology of the, or distribution of the radiotracers. So for example, a bone scan, you advise the patient to drink water and empty their bladder. So you try to empty as much as of radiation. For post-iodine, we advise them to have a lot of hydration. So we try to help the patient to get rid of the radioactivity as much as possible. But we can't say that, yes, nuclear medicine is higher radiation than CT in all imaging model, in all kinds of scans that we do, because this having this as a comment is not really true. The variation in biodistribution can be a reason for other than diseases, and this needs preparation. The only preparation you need in radiology is to be fasting, maybe for 4 hours, from solid food. And then you are advised to drink, or 6 hours, and then you are advised to drink a lot of water. It doesn't matter if you are having anti-thyroid medications, it doesn't matter if you exercised the previous day, it doesn't matter what meal you had. But when it comes to nuclear medicine, there's a lot of preparation required which will affect the biodistribution. And this is again to do with the specificity of the uptake. So a lot of preparations is required, and this is to be incorporated in your manual or in your SMS when you send it to your patients, what to do prior to the scan, so that you don't have to postpone, you don't have to cancel, like the anti-thyroid medications, the anti-angina medications, the captopril that you have to suspend before captopril renogram. We have a list of medications that we have to share and update and share with our referring endocrinologists and endocrine surgeons prior to doing MIBG scan. A very special and lots of preparations that we had a video, we had leaflets that we printed for prior to iodine-131 therapy and diagnosis. Cardiac PET needs a lot of preparation. FDG PET in general needs a lot of preparation. I'll show you some of the artifacts. So this is one of the preparations for the artifacts. This patient is having papillary thyroid cancer. We did a PET CT for metastatic disease. And look into the first one. This study is inconclusive, and we have to cancel it because the patient's blood sugar was above 10. She wasn't supposed to be injected. This was injected by mistake. Not to mention that there's also a lot of extravasation of the dose. But look into the intensity of uptake in the brain, and the brain particular, it's very low. So this is a low quality image. We couldn't report it. The patient had her blood sugar to be adjusted, came back. Again, we have to repeat. And then you can see that she's got a destructive lesion in the shoulder as well as a lymph node. So without a proper preparation, you can't really have a precise report. Or a patient who is a diabetic and he knew that he should have a good blood sugar control, but what they do is just inject the insulin prior to coming, and then you have musculoskeletal uptake of FDG instead of the region of interest. So this is again a challenge, and we do have this challenge because we have a lot of high population of diabetic patients, and I'm sure you have them here as well. Brown fat uptake with the presence of the PET, with the CT, it's not an issue, but again, look at the imaging alone, there is an uptake in the brown fat. There are certain preparations that you can do to reduce the brown fat uptake. And there are some things that I don't know whether to put it into pros or cons in imaging, like for example, the high sensitivity, low specificity. This applies to some of the studies that we do. For example, looking into the PET alone, if you look into this image, you would have thought that there is some disease in the lung, but looking into the CT, you know that there are consolidations. So this is something that we can resolve with having the CT fused images or the PET CT fused images. Or again, like for example, this patient was suspected to have unilateral hilar lymph nodes, highly suspicious. I don't know why, but the referring oncologist or the physician oncologist thought it's a Hodgkin's disease. And this was a relative of one of the doctors in the hospital, and they thought this is lymphoma, so we have to do him as urgent as possible. We showed that there is only uptake in this group of lymph nodes, and then he went for a transesophageal biopsy, and it was TB. So it's nothing to do with the lymphoma. But again, the intensity of uptake in infectious disease is as equal as that of tumors, and we can't solve this issue. I think that's the Green Mountain. I think that's real also, again, not photoshopped. Things that I put in just for you to think about, because I can't answer them, pros or cons. How beautiful is this specialty? Is so much advancing, because today I was in my colleague's lecture, Prof. Chin, and she mentioned a very interesting point of PIM might be used for screening. Now, and interestingly, I had this lecture prepared a few days back, and I said, we can't use it for screening. Now I have to change it. We can use it for screening. Now, not everything, not all screening, but for example, if you talk to the A&E and tell them nuclear medicine is specialty required, they will tell you, well, not probably, because it's not as useful as ultrasound. For example, anyone who comes with acute chest or anyone who comes with acute abdomen will be shifted to the radiology to do ultrasound, CT contrast, no contrast. For example, when it comes to nuclear medicine, we don't accept patient with acute chest or acute abdomen. We want to know, what is it that you're thinking about? Is this an advantage or disadvantage? To me, it's an advantage, because we give you a precise answer, provided you give us a precise question. I mean, you can't use it for screening, but you just ask, what is it that you're looking for? Is it pulmonary embolism? Is it pneumonia? Is it malignancy? And then accordingly, we can plan, what is it? How can we help you? Because we're not just CT and ultrasound. We have a number of radiotracers, a number of different scans that we can help you with, likewise in acute abdomen. The other thing that I really have this challenge, because I've been a head of department and planning the service in Oman for 10 years, research-based practice. Is this an advantage or disadvantage? It is an advantage if you have the resources, if you have the infrastructure, if you have the clear vision from the higher authority. But sometimes it is a bit of a disadvantage, because you can't decide what is enough. What is enough? Where to stop? What is the state of art? Am I doing fine, or am I just behind? And attending such conferences, once I told one of my colleagues, attending such conferences, I feel that we are still in the 70s or 80s and people are ahead. But again, it depends on who's your stakeholders, how much you can do, what are the requirements of your department. But we still have this feeling of, we really need more, and is there anything more that we want? And this is this kind of thing that I like, because it's more of ambition, and we can develop this specialty and take it forward. This is a very beautiful image of just telling you what is the state of art and when can you stop. I don't think there's anywhere that you can stop, because, okay, this is the FABI, and this is the image of the year in SNM in 2019, in which they have the gallium-68 FABI, and they are showing you the distribution in 12 different cancers. So FABI, probably it's not used, or maybe it is used, or a trial, or somebody started using it. But when you have only technetium and iodine and maybe gallium-67, do you want to go there? You know, when you see those images, do you really feel ambitious that, okay, I want to have more? And then there is a variable training, nuclear medicine. This applies to us as physicians, and this was a hot topic that was discussed in the first day. Where do we train? What should we train? How much we should have training? This also applies to the technicians. We have a combination of, we have radiographers running in nuclear medicine. We have nuclear medicine technicians having in nuclear medicine. We have both. Those who's been trained long time back in nuclear medicine technicians, they didn't have an exposure to the CT. And if you get PET MR, they don't have definitely anything to do with the MR. Those who are radiographers were an asset to us because they were very well trained and they worked with the CT before, and they knew the concept of the CT, but they have to go a lot of training for nuclear medicine. We don't have a unified training for those technicians / radiographers so that they can get trained and get the requirements. So you really have to invest a lot in it. Again, in the physicians, they are trained as radiologists and then subspecialize nuclear medicine, or they are trained in nuclear medicine alone and then they need a lot of training in radiology. Where do we fit? And this is another thing in nuclear medicine, and this will help you to decide what is it that you want. Is this an advantage or disadvantage? It is something you have to think up all the time. As I mentioned previously, we are so kind, we are so soft, we are so acceptable that we can fit anywhere. But is this something that you want, or you want to have something or a standalone department? Or with all the imaging that is coming, the PET MR, you need all the subspecialties. So should you collaborate? Should you integrate? Should you be one department, or you be different departments? And again, this is from Qatar. The one who didn't go, please visit it. It's a really nice place to go. Now what the take-home message is. Nuclear medicine, and if anyone tells you it's a dying specialty, you can have this. It's a diagnostic, prognostic, predictive, and intermediate endpoint biomarker in oncology, in cardiology, in neurology, in infectious and inflammatory disorders, and I've shown you some of the examples, which is mainly in oncology. It is a technology that is going into revolution, and the PET MR is really revolutionizing the PET system in nuclear medicine. Artificial intelligence is coming to us in nuclear medicine. It will be a game changer as well. What is not is, or for anyone, and please refrain from using it as unclear medicine. This is something that is going on, and it is a low spatial resolution when you can tell them yes, but this was in the 70s, prior to the invention of the computers. Now we have computers, we have the filtered back projection, we have the time of flight, we have a lot of things that happened in nuclear medicine. You just need to read about what is happening, advances in nuclear medicine. It is no more unclear medicine. So please forget about it, don't even use it. It's a dying specialty. I hope in those 30 minutes I've just told you, it is something that we are not even there yet. There's a lot of potentials, a lot of things that's happening, and we are not there yet. So if it's dying, I hope I just convince you it's not, and you can just tell them, we're not even there yet. And you know what? We have a new name for nuclear medicine. It is called New and Clear Medicine. Okay, so thank you.